Hello friends, I am back again. I am Dr. Satyanarayana Mysore, Head of Pulmonology. The purpose of talking to you all is to highlight our team of specialists, and not only that, to bring medical facts in such a easy way that everyone gets to understand and you are updated on your knowledge health domain health status. And I have the pleasure of welcoming Dr. Lokesh Veerappa, who is very dynamic orthopedic surgeon in our hospital and a good friend as well. So Dr. Lokesh, if I can ask you, traditionally the joint replacement, patients who come to me for a particular lung problem, but they will talk about, no doctor, I cannot go for a walk. It's my bad knees. And the next obvious thing is, I will say, have you seen an orthopedician? And most often there is kind of, I don't want to undergo surgery. That is the first thing I hear. And instantaneously the second one I hear is that if I undergo surgery, 6 months I will be on the bed, immobilized. But I think that is a myth in the current situation. Can you highlight on why it is a myth?
Yeah. Hello. And of course, Satya is a close friend and he's been generous in the introduction. And nice. So, you're absolutely right, Dr. Satya. So, there is a lot of myths floating around in the world about knee replacement as such. And of course, the fact that all knees that comes to us, they don't need a knee replacement. It's like we grade the amount of wear and tear. So, with the current lifestyle, there is a lot of sedentary habits and weight gain. So there are various levels of damage of the knee. When a person comes to us with a knee pain, so we actually get an X-ray done, we get an examination done. In that, we grade the amount of wear and tear of the knee. So it's graded as 1, 2, 3 and 4. Of course, 4 being the most severe bone-on-bone kind of scenario. And 3 is, it's almost there. Only in these stage 3 and stage 4 is that we do suggest knee replacements.
So what you basically are saying is that it is the lifestyle choices that we employ can years later end up in having very bad knees because the weight balance mechanically. In the younger age group, there is a cushion to prevent the thigh bone and the leg bone being apart.
Yes.
And with the wear and tear, it is the bone on bone that happens, which can be prevented even, number one.
Yes.
But despite having a very good lifestyle, suppose we end up in that, do you think your field of interest is being robotics for long length of time? So how do you employ robotics? I hear there are 2 separate robos in our hospital at the old airport road. So can you take me through that? If joint replacement is inevitable, if you do a robotic surgery, is it quicker recovery time? Can they walk a few hours later or a day later? And what about the conventional? So my viewers would want to know that difference.
Yes, Dr. Satya. So this is actually a new tool. I would rather not call it so new. It's been there for about 4-5 years with us. And this tool has really made a dramatic change in the way the patient recover from surgery. And also the precision, which makes it feel that it's more as good as the actual knee, the regular knee. So that is the good thing about robotic knee replacements. So the robotic knee replacement, we have, as you said, we have 2 robots in Manipal. And because of the volume of work that we do, we had to get the second one. And lot of people are aware of that and they are asking for it nowadays. So what does a robot do is, basically we do a CT scan of the knee and feed it into the robot. So now the robot knows the shape of the knee, the amount of wear and tear, and what is the size of the knee, everything it knows, bone-wise. Then in the actual surgery, we give them about 60 to 70 points around the knee. So it merges both the images and it gives us a plan. So this is the way we can do the minimum bone cuts and get the maximum benefit and best alignment. So then we have to approve it. We have to look at it, look at the plan. So this is what we got to do. And once we approve the plan, Then the robotic arm comes and it does the cuts, and it is so precise that to the minimum 1 degree, to the minimum 1 mm, it is precise. So it makes a perfect cut. So it is not surgeon fatigue dependent. So the first surgery I do or the 10th surgery I do in a day is going to be the same. So, and after that we fix in the implants. And as you said, the advantage is that because we are cutting open little, dissecting little, and we are precisely placing it, the rehab is fast, painkiller requirement is very low, and they are up and about very fast. So that is the beauty of robotic replacement.
Fantastic, fantastic. So also it would kind of avoid ugly situations where the cut has made that leg shorter or longer. Those kind of things are all taken care of.
Yes, yes.
The precision.
Yeah. So typically in a knee replacement, the lengthening and shortening is not so much of an issue, but in hip replacement it's a big issue. There are a lot of issues in US and UK where there is limb length discrepancy. One is short, one is long, and there were a lot of unhappy people and stuff like that. And this robotics has been a game changer. We can actually measure the length of the leg before and after surgery, and we match it up to the millimeter. So it's a perfectly aligned joint so that there is no lengthening, and it's perfectly okay to normally walk, and you can't even make out that person has undergone a replacement. So they'll be walking like any of us. Yeah.
That is good. That is good. In the sense, there is a kind of happy marriage between the technology and the orthopedician. It is not the robot that does everything. It is the surgeon who does the precision measurement, the pixel kind of functional unit of the image from the CT scan is fed into the system. Very good. Of late, I also know that your field of interest is moving into kind of challenging orthopedic interventions. And one of them is most people with the pelvic trauma do keep coming to you specifically. So why is that? Is it that pelvic trauma is going to be very bloody, very messy, number of bones in our pelvis, that is the hip joint and the surrounding joints, are too many? So dynamics are very mind-boggling. So take me through that.
So Satya is a very close friend, so he knows my pulse. And pelvic fractures has been a passion for me because it was something that people were very scared of doing, very wary of doing. So when I first came down to Bangalore about 20 years ago, there were hardly anybody doing pelvic fractures. And even now, after 20 years I've been practicing, there are only countable number of people who do pelvic surgery. The reason is because of the complexity of the anatomy, and people are scared about fixing pelvic fractures, and a lot of these patients had to be just put on bed rest, and they will be throughout the life walking with a limp. And a lot of these pelvic fractures bleed inside, and a lot of them die also. So fortunately, I have been trained in India and in abroad in pelvic fracture management, and we get referrals from all over India for pelvic fracture management. And here at Manipal, we are happy to say that we have actually saved many lives which would have been lost because of pelvic fracture, because of timely intervention. Because pelvis can accommodate about 2 to 3 liters of blood, and if they start bleeding, and unless we actually emergency surgery we do and we fix it, they just bleed to death. And because of our comprehensive team, see, we have a perfect ICU team, we have the urologist there, we have the gastrosurgeons there,
interventional radiology.
Absolutely. So all of us together, we have saved. There is one patient I remember. The patient came with run over by a lorry and arrested thrice in the emergency. 3 times arrested in the emergency with a pelvic fracture. And then we took it up, we did an emergency fixation, and the gastrosurgeons did their work. And of course, intervention radiologist also came in and did embolization of the bleeding vessels. And the patient was here with us almost for about 3 to 4 weeks, and then went home happily.
So these when you say fixing, it is external fixation, internal fixation, as the case may be.
Yes.
So there are a number of options to fix it depending upon the medical need at that point of time.
Yes, so this is one facet of it. One facet of it is the pelvic fracture life-saving fixations. The second facet of it is the acetabulum or the cup of the hip joint. It is three-dimensional and it's surrounded by a lot of important structures. So people, I have seen a lot of orthopedic surgeons are wary about doing the fixation of acetabulum fractures, and usually they let them on bed rest and the hip gets damaged and they will do a hip replacement down the line. So we, on the other hand, we do emergency fixations of acetabulum fractures also. In the sense, we recreate the joint so their hip joint can be staying normal for the rest of their lives. And it's the challenge of doing these surgeries that keeps us interested in orthopedic surgery, I would say.
Thank you, Dr. Lokesh.
Yeah.
A lot of valuable information has flown down in this interview, and I'm sure it will benefit the common man. And thank you for that.